This is my dear friend and my dentist, Mary Ellen Chalmers. Her CV is really long. She is practicing integrative and functional dentistry, and I suspect she'll explain what that means. She's a regular dentist from Tufts School of Dental Medicine. And then she was, just because she didn't have anything better to do, which is an understatement, she'll receive her master's in orofacial pain and oral medicine from University of Southern California this year. She's a naturopath from the American Naturopathic Medical Association and the American College of Integrative Medicine and Dentistry, as well as a certified functional medicine practitioner with IFM. The rest of her CV would take the rest of the hour. So we're just going to go ahead and have the conversation. We've been friends for a really, really long time.
Hi, since 2006. That's when I took that sport class in San Francisco.
And what made you take that class?
Sandra Megan and Patricia Lawless. Megan had been saying to me for a couple of years, because I think they got started around 2001, 2002 with you, 2001 with you.
Yeah.
And she started saying to me, because I was her patient and close friends with both of them, because we'd been in Berkeley for years. And she started saying to me, I think there's applications for dentistry in this. And I was so overwhelmed with starting the new practice up here in Santa Rosa, and we were building our house, and I had these two girls, and I was, Kristen got injured playing soccer because, that's both girls were highly athletic from 8 or 9 through college. And so she got injured, and it was a hip flexor, and she got cleated up around her hip. And I took her in, I think Patty was actually the one who treated her. And the contusion went away. And I said, and she was able to play. She had a big tournament coming up, and she was able to, they were talking about not having her play. She walked off the table. She was fine. And I said, what is this? And Megan said, this is what I've been telling you about. I have been talking to you. She said, that was June, and there was the sport class was in July. And she said, take that sport class. Pat and I are going to be there. Take the sport class with us. She said, I think there's applications for dentistry. And if there isn't, you'll have something that you'll be able to use with the girls, because they're going to need this and of course they still do. But so that's how I got started. I started at the sport class. And what hooked me was the cytokine paper. You had just published the cytokine paper. You had gotten the data, you had finished everything at NIH, you had just gotten the cytokine paper, and that was ready to go. And it was watching that cytokine data, because in my world, I had made the connection that our primary job as dentists is to eradicate inflammation. Remember I used to talk about a mouth at peace before functional dentistry. I used to talk about creating this mouth at peace, that our job was to create a mouth that wasn't inflamed, whether it was periodontal disease, whether it was reaction of the metals, whether it was mercury, whether it was root canals, whatever it was, we had to address those inflammatory factors within our patients and create a mouth that was uninflamed. And that's what hooked me, was cytokine paper.
And the thing that I remember was, because you're a dentist, you wouldn't touch anybody.
Now I came back and took the core in December. That was at the core.
And so in December, you were dodging it. And I remember grabbing you by the scruff of the neck and saying, sit down and put your hands on this person's neck. And you went, and
next.
But I love the phrase, a mouth at peace. That's what a wonderful way of describing reducing inflammation. That's just delicious.
And that's what hooked you then too. I think that's when you said, because you had used that same phrase back then, because that was my perspective. Now, of course, it's bigger, and I have different language to describe how we interact and how we need to interact. That was the beauty of FSM. And 2006, December 2006, I took the core and then got not a custom care, I had home care. All you had was a home care and an auto care. And you taught me how to manually program the auto care, because there was nothing really short of a blue box. But I needed to be able to run automatic protocols while I was treating people. And to develop the dental protocols, I sat at the chair, manually programming in to figure out the frequencies for all the dental protocols. So then I came back, my first lecture anywhere was for you in 2008, when I laid out the rationale for FSM in dentistry and where to use it and how to use it.
There was something about from the mouth to the gut it was about how health starts in the mouth and the digestive system, and how all that is connected and how FSM can help.
Exactly. And the other, exactly. It was how we can eradicate oral inflammation. And using FSM as a tool to do that. I used it with periodontal surgery patients right off the bat. I used it with implant patients. It was the implant patient was how you wound up treating horses. Because, yeah, I don't want to say her name because of HIPAA, but that's how.
Already in the book.
It's already in the book. She gave us permission. Yeah. But it was an implant. It was an implant patient of mine.
And then it was orthodontia.
So that was Jackie.
Yeah.
And that's what led to the patent. And it was new injury. Jackie did phase 1, where you just have the 4 brackets in the front and the little wires, and she was miserable, and she made John and I miserable. And so when we were looking at phase 2, where they put her whole mouth in appliances, we thought, oh, we're never going to survive this. This is just going to be,
it's Jackie.
Going to be bald by the time she's a month in. So as a lark, I thought, shoot, why don't I, so I put 2 pads here and 2 pads, actually I didn't, I put gauze. I got alligator clips and figured out we put gauze in her mouth, wet gauze in her mouth, and electrodes on the back of her neck. And I ran new injury because I had dental protocols, but we didn't have custom care at that point. This is February 2007.
Just before it came out.
Yeah, just before the custom care came out. And that was a game changer for dentistry, was to have the custom cares. But no, I put the electrodes on and we ran it and we never heard from her. I don't know, for any of you who've ever had braces, it's excruciatingly painful, especially for the first few weeks, because as you're putting pressure against that periodontal ligament, all the sensory fibers, you're putting pressure in order to stimulate the osteoclasts and the osteoblasts. But in the meantime, the sensory nerve fibers are just on fire. And I still remember from when I had my braces on at 12. So we put it on, she had no pain. And I thought that's great, and completely missed her 6-week retie. We were busy and went, oh my gosh, 12 weeks in, I went, oh gosh, I better get her back there. So we took her back. She'd been in the appliances for 3 months. An orthodontist came out and said, oh my God, she looks amazing. And I said, oh, that's nice. And then she said, yeah, and everything has moved so quickly. We're putting her in rectangular wires in a month. And I thought, oh gosh, isn't that cool? And I started to walk away, and then it hit me that it was the FSM, that basically rectangular. So they put round wires. You have a bracket that's rectangular, and a round wire just minimally engages the bracket, and it's to induce a softer, more gentle force, rather than when you put in a rectangular wire, you actually lock in the bracket, and that's when you really can start to tip and torque and move the teeth. Normally rectangular wires are put in anywhere from 6 to 9 months. So we were dramatically ahead of schedule. And in fact, Jackie finished a 2-year treatment plan a year. And I said to the orthodontist when she said, yeah, she's going in rectangular wires, I said, we've been using this frequency specific microcurrent. And she said, what does it do? And I said, it eradicates inflammation. And she's had absolutely no pain with her braces. And she said to me, that doesn't make any sense. We have to have inflammation in order to be able to move teeth. And I said, yeah, but what if you don't? What if you, at the end of the day, you really don't? And so then I dove in. It's actually working on the IL-1 beta and all of the inflammatory cytokines. I think that it has because it's IL-1 beta, so people with the IL-1 beta SNPs are going to get the shortening of roots. I think it has real efficacy. And so when I happened to mention this to our dental supply rep, he's the one that said, shut up right now, patent it. because we were within the 1 year and everything else.
And you hadn't lectured yet.
Hadn't lectured yet, exactly that. The patent was put into, because I was lecturing in February 2008, and the patent was, we had a provisional patent in a hurry because I think it was January when he said, you better patent it. And I remember having a conversation with you and we didn't think it could be done. Actually, no, it was the fall. It was the fall of 2007. And my sister Eileen's had a patent attorney, happened to have a patent attorney, because yours said, oh, no way it could be done. My sister Eileen happened to have a patent attorney over for Christmas and was talking to him about that we had figured this out and nobody else in dentistry was using it. And he's the one that said, he said, have her give me a call. And so I gave him a call after the first of the year. And he said, I don't know, let me think about it. And he called back 2 days later. I was in that office and everything went from there. But yeah.
There's just so people listening, because we have both practitioners and patients, just so people listening, when you can't patent, number one, you can't patent something after you've taught it. So FSM was not patentable.
For you.
In medicine, you can't patent a medical procedure. So if you develop a new way of doing gallbladder surgery, you can't patent your surgical technique. But if your surgical technique can require a gadget, you can patent. In medicine, you can patent the gadget that it takes to do your special surgical technique. So that's the way medicine works. And the way Mary Ellen patented, or Dr. Chalmers patented FSM in dentistry, is that there's something called the dental exclusion. So dentistry is exempt from the patent rules that regulate medicine.
So we patented the intellectual property. We patented the application of the frequencies from 0.1 or 0 to 999.
Yeah.
It with my protocols. Yeah.
And so that's how it is you came to have the Ruth Johnston Award in 2009.
14.
It has to be an
Or
odd
13.
9, 11, 13.
15, somewhere.
Yeah. Talk about, you make the distinction between, and this is fascinating to me, we have two avenues I want to explore. The difference between biological dentistry, which always makes you make funny faces, and integrative dentistry, which is what saved my life. And then what it is that you're going to be talking about at the symposium about how head, neck, and face pain and the neurology of head, neck, and face pain affects what we do with FSM. But practitioners and patients alike, the difference between biological dentists and integrative functional dentistry.
Yeah, I put integrative dentistry in because it just means I work with a bunch of different practitioners. I'm going to work with these DOs, DCs, acupuncturists, head and neck. We work with a variety of practitioners, but it's really functional dentistry. And dentistry really had its birth when Lisa Patera and I started practicing together. And she was treating you and I was treating you from 2010 to 2013. And what functional dentistry does is it actually allows us to individualize and personalize care using the functional medicine matrix and the timeline, antecedents, triggers, mediators. How it's different from biological dentistry is that I think biological dentistry is a wonderful place to start. It's critical. I think everybody should be at a minimum a biological dentist. The principle is that our mouths are attached to the rest of our bodies. I think we all agree with that. Though when I think back as to how much we've changed in 15 years, when I took IFMCP in 2008, Tom O'Brien was talking about the gut, and for all the IFM graphics, the gut stopped here or started here. Yeah. This whole part of the gut was not, So it's a good start because it acknowledges that the mouth is attached and has direct impact on the rest of the body, and that it's incumbent upon us to use biologically compatible materials, that we need to restore patients with biocompatible materials. What functional dentistry is, and Lisa and I started out calling it functional medicine-based dentistry and we toyed with a bunch of different names, but it was really in 2013 when I developed the matrix, the functional dentistry matrix, which anybody who's taken an IFM class is aware of, that we really, it's morphed into functional dentistry. And it's the application of functional medicine, which one of the tenets of biological dentistry is absolutely no metals in your mouth. I don't believe that. And I think that it depends. If you're an autoimmune response to metals, then you shouldn't have that particular metal. But there's a man within IAOMT, the International Academy of Oral Medicine and Toxicology, of which I've been a member for many years. It's a wonderful biological dental organization. Jess Clifford, who developed the Clifford test, his perspective was it isn't the fact of the metals, it's the dissimilar metals that are at issue. And
so mercury is not a problem?
Mercury is a problem. Nobody should have mercury in their mouth. No, nobody should have mercury in their mouth. Mercury is a toxin. Mercury is a metal, but it's also above and beyond a toxin. But
what metals do they use for fillings that aren't mercury?
We use something called an ormister. We use Voco. There's composite resin, but the problem with a lot of the composite resins is that they contain BPA. So there are materials out there that are BPA, BPS, and phthalate free. We use a Voco product in our office. We've been using it since January of 2016, and it's wonderful. It lasts and lasts. It's very aesthetic. And then in addition, we are using ceramic implants. The ceramic implants are tricky, and they're not equivalent to titanium implants. We do have patients with titanium implants, but I'm very careful to use like Straumann, and I have no commercial affiliation with any of these companies whatsoever. It's just what we use here and what we found to work well. But I mean, you're a perfect example, if you don't mind me. The only metal you have in you is titanium, because we took everything else out. So it's when you have
just let me interrupt, just so everybody knows our background. I had a stent in 2007, and by then you were already my dentist. And you said, that doesn't make sense. You don't have any risk factors. This is single vessel, single lesion. What's going on? So we went to Stanford and we did a CT scan. Red is normal. And then in 2000, was it 8 or 9? It was before it was right after my first hip surgery, I think. So it would have been January of 2009, maybe March of 2009.
We did the CBCT.
Yeah, the 3D cone beam came out. And what you were looking for was an infection in my mouth that was causing heart disease, which is a completely new concept for anybody, for my cardiologist, for my GP, for anybody that's listening. The fact that root canals never don't fail. And you were looking for something in my mouth that caused me to have a 99% blockage of the LAD. And there it was.
And the hip deterioration.
Oh yeah. And I needed it was after my right hip. It must have been just before my left hip or something. And that's it, you found it. So that's when we started 9 jaw surgeries.
Yeah.
Something like that, and lots of implants.
Lots of implants.
For metals allergy.
We did. We tested you for metal allergy, and you came back positive for metal allergy. At the same time, Lisa tested you for methylation defects. And she and I had already put together this piece that if we see a patient with that a methylation defect, a metal allergy, the third part of this is celiac. And we took a look at that, and you up until that point had no idea that gluten wasn't your friend.
No.
So it's a pattern that we've seen over and over again, this pattern between methylation defects, metal allergy, and celiac. And it goes the other way. If they've got a methylation defect and we've diagnosed them as a celiac, you better be darn careful that about metals and implanted metals. So that's an application of functional dentistry where we're not using this absolute rule that nobody should have metal, but making sure, and the only metal that works for you, because you were allergic to gold, you were allergic to nickel, that's why all the gold had to come out, but you did really well with titanium. And yeah, and so I remember the conversation with the orthopedist who,
His shoulder, that was hilarious. I'm sitting there with 6 fractures between here and there and drugged on fentanyl. He comes in at 3:00 and says, we're going to do your shoulder surgery tonight at 6. And I said, what kind of hardware are you going to use? He said, stainless. And I said, no, you're not. And he said, why not? And he said, I'm allergic to chromium. There's just a little bit of chromium. I said, that's like being a little bit pregnant. Then the fentanyl hit. I dialed you and I said, Mary Ellen, he wants to use stainless. And then I said, yeah, you talk to him. And handed him the phone. You should have seen the look on his face. He did his surgeon thing. Whoa. And then you started talking and he went, whoa. And then he was really quiet for 30 minutes. And then he hung up the phone. I came to and he said, yeah, I have to find titanium hardware and have it be here by noon tomorrow. And so he did. He's an amazing surgeon. But it was that conversation.
And it's actually well accepted now within the orthopedic literature. This year's presentation, annually, I'm part of the environmental health team at IFM for the advanced practice modules. And in the early days when I was presenting this material, I was presenting dental studies around metal allergy. Now I'm presenting orthopedic studies. And orthopedic studies that are actually saying that this ELISA test, this lymphocyte transformation test, the LT test, which identifies delayed type 4 hypersensitivity reactions, that is actually better than a patch test. And there's evidence about that. And there's all kinds of literature about
IDE is not usually the problem, it's IgG. It's like, it's delayed.
Right. And actually it isn't even IgG, it's lymphocytes, it's T cells.
Oh my gosh.
Delayed type 4 hypersensitivity is your T cell reaction.
Yeah.
So, and IgG is another part of it. But the problem with dentists is, and God bless Jess Clifford, I love the man. I learned, he passed away a couple of years ago. He was an incredible human being and a brilliant man and lecturer. And what he taught me so much about metals. It's basically electrochemistry. We divide that anode and cathode table. And when you've got titanium at one end and mercury in the middle, and then your gold or platinum down at the other end, you can set off these tremendous arcs and batteries. And I remember you had that going on.
What did you tell? It was
the Euro potential meter that Neil Nathan was the one who had me get that. Because I worked very closely with him when he was practicing in Santa Rosa, and he called me one day, 2009. He said, I want you to start testing current in the head. And my first thought was, oh, really? Really? He said, Mary Ellen, I'm not talking about EAV, electroacupuncture, according to Bowl. He said, I don't want any of that. He said, I just simply want to know, is there a battery going on at the base of my patient's brain? And when he put it that simply, because which he does, right? He dials it all down into simplistic little, I said, oh, yeah, maybe I should be paying attention to that. And I was, of course, immersed in developing the protocols on FSM and everything at that point. We're talking 15 years ago. So it all made sense. And particularly if we were going to talk about efficacy for frequency-specific microcurrent here, if we had competing galvanic currents, I don't know if there's a study. It just, to me, intuitively, we should get rid of the galvanism in patients' mouths. And so that's part of our exam. We check for that routinely. And patients with galvanically active mercury, it's a real simple sell to have them understand why that particular lesion needs to come out. But the other thing that functional dentistry does is, for example, with our patients with hypertension, we have the conversation about the 2011 Mark Houston paper that talks about hypertension and mercury, and the fact that the mercury actually damages the endothelium and will lead to hypertension. And so when we're talking with an autoimmune patient, that's the biggest change, I think, or biggest, seeing many more papers on the effect that mercury has on autoimmunity. And in terms of ANA, elevated ANA, preclinical symptoms, that's in Haynes data from 2015. So we're having conversations about patients' disease and then and relating that to what the different ways in which their mouth is being restored or the disease they're exhibiting. And then functional FSM comes in there. It's FSM in functional medicine. And and that the results together are exponentially more than.
I don't know how you can do one without the other.
Correct.
Functional medicine is awesome, but it takes too long and it costs too much. And FSM by itself, without the stable state that's created with a functional medicine approach to health and a stable state, FSM by itself won't hold most of the time.
Mm-hmm.
And so you combine the two, and each one, it's synergistic.
Synergistic, it is. Yeah.
Speaking of which, I just need, Kevin has a question. What frequencies would you use to treat a potential root canal? And I don't know what your answer is, but my answer is none.
Exactly that.
We do not treat infection, period, end of discussion. And you can correct me.
No, I'm not, because we figured that out in 2009. Remember, that was my 2009 presentation. We had, so with the use of FSM here, I had a periodontist using it in her practice. We had Eric Gordon and Gordon Medical using it, but it was really being widely used within Santa Rosa. Periodontist who was using it had a patient, you put in an implant on a patient in an upper molar, and within 24 hours, that patient was in the ER on IV vancomycin with a very serious infection. And our first response, because I remember you and I having this conversation, our first response was, ooh, how do we know about these deep space infections? And where we came to was that what would have happened if we hadn't used FSM is that she probably would have had a failure of the implant here. She would have developed chronic health issues, that these deep space infections, and I'll be talking about the fascial planes and deep space infections during my presentation. It'll be a little bit, most of it is going to be about pain pathways. But if without running FSM in these deep space infections, they're all encompassed by scar tissue and fascia. And by running the frequencies for fascia, we allow these infections to drain.
It was inflammation. You treated her to reduce inflammation.
4142. Yeah.
And then she ended up. And then you came back the next year and said, remember last year when I said we shouldn't run inflammation if there's infection? This year I'm telling you, you have to run 40 or reduce inflammation to discover the infection. And there's no way to fix the infection unless you remove the inflammation that's encapsulating it.
Encapsulated, yeah.
So,
and FSM is critical for that. So what's evolved? We learned a lot. We learned a lot in those few years. But with respect to root canal, so how I use it currently in my practice, I developed that surgical systemic protocol that we treat patients with when they're having dental work done. The kidneys, the liver, it's basically supporting the adrenals, liver, kidney, and then concussion at the end. And patients do very well. Particularly, I have used it a lot to treat Lyme pain, my medically compromised patients who find it difficult just to sit in the chair and have their dentistry done. We use it with surgical cases. Surgical cases, it's magic. Yeah, you don't, the patient with the implant, you could see that there was an incision made, but there was no swelling, there was no redness, there was no bleeding. And you could open up and see that there was a surgical site, but it was simply a line where the incision was with sutures. There was no other evidence of trauma. So
when I tell people, it's like I've had 9 jaw surgeries. So we had 5 to take out the infection and the failed root canals, and then another 4 to put in implants and do this and that.
But we didn't understand at that point.
But there was no swelling, no bruising, no pain. And by then you had developed the surgical systemic protocol. So I didn't even have an anesthesia hangover. So it was pretty fun.
It was fun. And I think what we ultimately understood with you though, is it was the mold, right?
Eventually So
it was the mold, but And that's an important piece. I have
What happened, just so everybody is on the same page, 2014, I'm sitting there with Neil Nathan, 15, eating lunch, taking my digestive enzymes. And he said, why are you taking digestive enzymes? And I said, I am in pancreatic failure. I don't make amylase, I don't make lipase, so I just take enzymes. And he said, you need to come see me. So I came in June to see him, and he said, I want you to test your gag reflex. Well, I didn't have one. My palate didn't raise. He said, your vagus nerve doesn't work. He tested me for mold. I had Stachybotrys exposure, probably in 1998, accommodated for it for years, and then had a re-exposure in 14. And what ended up happening was the jaw infection. When Jarvis did it, you could see a fistula.
everything was into the sinus, right? The infections were communicated with the sinus.
And then on the right side, it was like a screen. It wasn't a fistula. There were multiple holes through the lamellar bone up into the base of the sinus. Then there was biofilm. Then there was mold. Then there was biofilm. And then there was an aerobic infection. So I had the layer cake of anaerobic from the jaw, mold, a biofilm, mold, and then aerobic. So I was on antibiotics for 6 years, from 14, maybe 13, until 2019 was when we finally got it. But it was the combination of all of them that we had to deal with. Like, why are you on antibiotics for 6 years? Because I have a bone infection. So I was on oral antibiotics for the bone infection caused by the root canals. I was on nasal spray and binders for the mold infection that was layered on top of it. And I'd say with actually starting about 4 or 5 years ago, I started treating the vagus every night to turn it back on. And so it all plays together.
It does. It does. I have this will be one of the cases that I present. I've got a bunch of cases to present, both at the symposium and with the advanced, and patient with 6 root canals in her maxilla. And this is, so I'm going to talk more a little bit about root canals and the push-pull that we have, but the saying in our office is root canals are good till they're not. And I don't advocate taking them all out. The infection, I once had a patient participant in a seminar say to me, why do you hate all root canals? And my late husband was an endodontist, right? And he was very much a part of this. No, he retired in 2012, referring to himself as a preacher that didn't believe in God anymore. And he was a part of all of this, but we've made significant strides with respect to eradicating the pathogens. Valerie Cantor in LA is really leading the charge with that. Mercola interviewed her actually 2 years ago now, it was either this past January 21 or January 22. So I'm not an advocate of root canals per se, though it is important. There was studies that started being published in 2010. So let me just say, I'm not an advocate of root canals, but I'm more mushy on those than I am mercury. Mercury, nobody should have mercury in their head. There's dental schools, some of the dental schools aren't even teaching it anymore. My younger daughter is a 3rd year at UCLA. She's going to get through UCLA without having to put mercury in a patient. Yeah, and they don't even have it in the pediatric clinic. The FDA stance on mercury dramatically broke lockstep with the FDA in 2020, September of 2020, finally. Yeah. With respect to the brain and this concept of proprioception, that when we tap our teeth together, there's proprioceptive impulses that go to the hippocampus. And it's a long body of research. I could talk for 20 minutes just simply about that research. But it really, the old biological dentists were, again, Jarvis has done so much, to Dr. Bob Jarvis, because when they were taking these teeth out and just raising the bone, and patients couldn't have implants, and it was really problematic. So in our patients that are nearly edentulous, 1 or 2 teeth, it can't be infected. You have to manage the infection. If there's a periapical radiolucency,
On
don't.
3D cone beam or X-ray?
Oh, either. 3D cone beam is going to be much more sensitive. If there's a periapical radiolucency, bye-bye. I am not a fan of retreatment. It simply doesn't work. Maybe if you have a patient that bumped their front tooth, that if they needed a root canal on a front tooth because of trauma, there was no infection, they can't lose the front tooth. Root canal was probably not done well when they were a child. We might see those teeth recover, but we tell patients, fine, do it, but no, it's a temporary fix and it's a terrible financial investment. You may as well just take it out and put an implant in. And that's more my perspective on that. However, Val Cantor has made, and she's using frequency specific microcurrent in her office.
Yay.
Yeah.
Well done.
Yeah, she is. So all of her patients are getting it and using it. She's using it too right now. And again, this will be another case that I present where we have a auricular cancer case with 70 gray of radiation. And there's a defect. Stanford actually was going to reconstruct her mandible with her fibula. But when she was told that she would never walk the same again, she said, I need another way. So actually we're using FSM, we're using ozone, we're using PRF and Val's laser. And this is a patient with osteoradionecrosis. Yeah. But so when you have your osteoradionecrosis patients, you take that tooth out, it's a disaster. It's just a disaster. So we are endodontically treating those teeth, but they're being treated with ozone. They're being treated with a laser. They're being treated with a gentle wave, all of these advanced technologies. So to have a run-of-the-mill root canal done at a general dentist or an endodontist, very picky about the endodontists we use because they have to have invested in the advanced technologies because standard endodontics just doesn't cut it. And the literature is full of studies, systematic reviews, very high quality studies that talk about the level of systemic infection with respect to endodontic lesions and endodontically treated teeth.
Speaking of infections, Shen has a question. Tooth extraction due to root canal gone bad. We're talking about this on Facebook, blah, blah, blah.
I saw it.
Waiting for antibiotics to fully work, bone graft to fully grow back. If I remember correctly, it takes 6 weeks for bone to heal.
You need a minimum of 6 months.
I remember.
You waited 6 months. It's 5 to 6 months. So your bone heals, but it doesn't. That socket isn't fully filled in for a minimum of 6 months. You have to. It's all about the integrity and the quality of the bone. Sometimes they can do an implant in 4 to 5 months. We're always safe. We wait 6 months. And integration.
I remember going almost a year with no molars.
That timeline really hasn't changed much in this office.
No, it's like I'd rather have an implant into healthy, solid bone. And even at that, we had one fail. Remember this one over here, whatever this one was.
Immediate implants are a possibility.
Seriously? How do you do that if you remove an infected tooth and you put
no, not an infected tooth. No, if you've got someone who have a patient who doesn't have a root canal, the tooth broke off at the gum line to caries, they're going to take it out, put it back in. Yeah.
Have you ever seen FSM on its own resolve an infected root canal?
No.
Me either. David says he was.
And nor have I been able to get FSM to regenerate the pulp. My biggest hope in the early days was that we'd be able to, because I had some pulpal inflammation protocols, that we'd be able to intervene and stop that pulpal death. Now, Val and I are working on it, and she's written some protocols, and I'll have to check in. I can check in with her before I speak.
Wouldn't it make more sense to run the frequencies for infection to change cell signaling around the infectious agents? So we've got, what are the infectious agents that occur in the mouth? I had entamoeba.
You had entamoeba, you had staph, see everything. It can be HPV.
Staph, strep, all of it.
And mycotoxins. And we weren't running frequencies for mycotoxins, and you had mycotoxins is part of it. So there's just the number of organisms is just massive, particularly if you look at the oral microbiome. We're really beginning to understand. They've identified, back in 2015, we started to identify the pathogens within the oral microbiome, and now we're having a better understanding of how the pathogens change and not how the pathogens change, but how the flora changes, depending upon whether you've got a cancer patient versus a periodontal patient versus the changes in the oral microbiome is significantly different dependent on that. It would be, that's my dream, be so, though I will say, we're very using ozone. We do not expose the nerve. So when I'm treating a person with deep decay, if they don't have obvious symptoms, I'll remove as much as I feel comfortable with, because I don't want to actively expose the nerve. That typically doesn't work out very well. But even if I leave a millimeter or two of tooth structure that's got some infection, we ozonate, and then I use it's a product called BC Liner, which is a glass ionomer based product. And sometimes I'll use another product called EndoSequence, but we'll use something that goes then on top of these deep areas to remineralize the tooth structure, and then put a composite or Ormacert or Boco products on top of that, and put a provisional crown on. And very rarely do we have teeth go to endo. I used to run frequencies in those instances, and I don't at this point anymore, because what would happen is we'd end up, if it was a tooth that was going to die, it would die a painless death, because we get rid of the inflammation. Excuse me. We get rid of the inflammation, but the nerve would still die, and we'd take an x-ray 6 months later, and there'd be a periapical radiolucency in the bone.
Did you ever use the frequencies for infection? Yeah.
Oh, yeah.
And inflammation.
Pardon?
You'd use the frequencies for infection and inflammation.
Putrefaction and the whole, yeah. I think maybe tweaking it. Val had some thoughts. Honestly, when Val and I started to work on it, and I was knee deep in this master's program that I've just finished. So I think that will circle back around.
You're all very glad that you're finished with your master's program.
Dissertation done. Yeah.
Yes. Yay.
Yes. Yeah. So I think that will resurface again, and I can take a look at it and have more bandwidth to work with. But I needed this piece for my education to be able to really put the FSM functional medicine pieces together, and to have that foundational academic understanding of orofacial pain, oral medicine, central pain. It was a rigorous program.
What was your dissertation on?
It was 18 cases, right? It was 18 cases. It was remember I showed you some of the cases when you were at my house earlier this year. So it was 18 cases. They ranged in anything from that cancer case that I've told you about. Another case that I'm going to be presenting was a patient that had an antrilith, a big polyp in the sinus, corticated. It was remains from a root canal extraction that didn't go well. There were tooth fragments in there. There was mercury in there. There was gutta percha. It was just this nasty mess. And everybody kept injecting her with ozone. And it wasn't until she got to Brigitte Foss, who referred her to me. And I went, this is corticated. So we had Jarvis do the surgery, took it out. Bridget did the FSM. And took it out, he did ozone, he bone grafted, but the FSM made a huge difference because she was in chronic pain. And she also had 2 different types of parasites. Her gut was a mess. So that'll be a case I'll be presenting in detail. Tinnitus. This is my research paper at USC was on tinnitus and TMD and the dramatic link between the two. And I think, treating the tensor veli palatini and the tensor tympani, both of those muscles are dramatically affected during tinnitus. So I think FSM has a foothold in there. I'm anxious to get going on that. I think we need to use FSM with burning mouth. I mean, burning mouth, a lot of burning mouth, there's a lot of reasons patients complain about burning mouth. The gold standard burning mouth, burning tongue, where they do the tongue biopsy, it's due to neural atrophy. So why can't we treat that, right? We do.
When you look up burning mouth, it says it has something to do with food allergies.
Oh, that too. It can't. Burning mouth so a diagnosis of burning mouth is a diagnosis of exclusion.
Yeah.
But there's a feature where the nerve fibers have atrophy.
Basically, phantom limb pain for your tongue.
Yeah.
I'll be damned. Limb pain's easy.
Exactly.
That's 89.
Exactly. Exactly. So you just have to understand, is it a nutritional deficiency we're dealing with it? Is it a B12 deficiency that we're dealing with? So I have a burning mouth case that we can talk about, and all the different, I basically have a 4-step diagnosis that we start with the low hanging fruit, right? And then we go from there. But I have a way in which I progressively rule out burning mouth. But traditional oral medicine or oral facial pain, God bless them, they're treating it with, we're going to clonazepam, right? We're going to do our clonazepam or Klonopin, the swish. Swish Klonopin, spit it out, because you don't want to swallow it, you're going to get addicted. But that's basically how they're treating it. And
does it work?
Well, yeah, it works, but there's long-term consequences with that systemically. So there's so much that FSM can add to this field of oral facial pain and oral mucositis. Look at with the throat cancer patients, and we don't have patients have oral mucositis anymore. So it's just the 18 cases were a range of cases. I was very fortunate. The program director, what I learned from one of my friends, a functional medicine friend, Andrea Ellenboss, who preceded me in the program, was shot down routinely. And she said, don't let anything come out of your mouth unless you've got studies to back it up. And of course, having presented for IFM now for 13 years, I did. And I know how to talk the literature. And you're all about the literature, right? FSM is all about science, the science of the scientific literature. So it was easy for me. And so every case had an element of medicine. And the majority of the cases also had an element of frequency specific microcurrent. And so there's presenting the literature with that along ozone, but staying within a traditional oral facial pain, oral medicine diagnosis, but using some of these different modalities to be more effective in our treatment.
And they accepted the FSM part of the case reports?
I have data, right? Because the science doesn't lie. When I have your neuropathic pain paper, when I have the cytokine data paper, when I presented the data and the papers to go with my treatment rationale, how do you argue? And people get better. How do you argue with that?
That's so exciting.
It's fun. It's fun. And yeah, it's just, I'm nowhere near ready to retire. So
I know the feeling. Oh, David, I think we've already answered this. David said he's always wondering if FSM alone could have returned the remaining 60% of the lost jawbone due to infection.
Won't put back what's not there.
Yeah, can't get it done, not when it's infected. Because what people need to understand is that the first thing the anaerobic bacteria do, you taught me this, the root of the tooth is like straws, and you take the nerve out so it doesn't hurt, but you can't sterilize the straws.
The technology that Val's using can. She's got unpublished UCLA research showing 98 to 99%. I'm not going to use the word sterility because it's not sterile, but disinfection. Okay. So we're better at it.
Before, old root canals, like the anaerobic bacteria, go out into the bone, kill the blood supply, and end of story. You can't build back bone without blood supply, and the blood supply, the bacteria take care of. Is that correct?
Correct. And would you say that FSM would stimulate angiogenesis? Do we stimulate angiogenesis? I know ozone stimulates angiogenesis. There's a medication called pentoxiflline with vitamin E that stimulates angiogenesis. So maybe that's why Val is using plasma PRF stem cells. Yeah. In this woman with that we're actually, FSM is playing a very vital part there in maintaining the inflammation. Is using the osteonecrosis protocols that we've developed. Yeah. So it's an integral part of it, but you've got to have an agent that's stimulating angiogenesis. And I don't know that in and of itself alone, it will do that. I don't know.
We'll find out. We have 2 minutes left, and that gives me time to ask you. So we have now a number of dentists that have taken the FSM course.
Yay.
Yeah, like we're into double digits of dentists. Wow. Yeah. And the next question they always ask is, when is there going to be a course for dentists?
I have the bandwidth now.
Huh?
I have the bandwidth now.
You
Yeah,
have bandwidth now that you have your master's finished. So I promised everybody that we're going to talk about that. We don't have dates yet, but we have a plan, and it's
and I think the collaboration, I'm excited actually, because it was pretty, I was alone wolf for a while. But what I think what I have seen with functional dentistry, I think we'll also see with FSM is that it's the collaborative knowledge. If we can get a dental group together, we may be able to figure out these issues of what are our protocols for growing bone back. Maybe we can keep those teeth, working with Val, because she's all about regenerative endodontics. So what role can FSM play in regenerative endodontics? Because we know it affects cell signaling. So as we dive deeper into these emerging topics, I think the future is limitless. I really do.
Oh, that's so exciting. And I'm excited that you got Val on board, and you have the bandwidth, and you have the connections in the dental world and the functional medicine world to bring all three of them together to do what you're doing with FSM and dentistry.
I'm excited. It's just, as I said, it's work is not work. It's just fun.
It's fun.
Lots of fun.
It's why we do this.
Exactly.
It's 4 o'clock. I told you this would be the fastest hour of the week. This will be fun. And I think we got, Alf says, thank you for a wonderful webinar. Yay. And that's no questions. So we're all good.
Well, I look forward to seeing everybody in February.
I'll see you in February. Thanks so
Okay.
much.
All righty.
Good one.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.